You get a lot of trick-or-treaters?
No.
No,
trick-or-treaters at all.
Oh, that's too bad. Well, I think I had more trick-or-treaters than ever before, and it's kind of interesting because that leads us into what we're going to talk about today, controlling things that we don't want to happen, which would be strokes. So, Dr. Antoine Trammell, introduce our guest.
Well, thank you, Miss Emily P. Bush. I appreciate that. All right, everyone, I'm Antoine Trammell. It is my pleasure to introduce Dr. Fadi Nahab to you. He is currently the medical director of the Emory University Comprehensive Stroke Center and the quality director for stroke at Emory Healthcare. Dr. Nahab received his medical degree from Loma Linda University. He then did an internship at UCLA and decided to come to good old Georgia for his neurology residency. He then completed a fellowship in vascular neurology at Emory, and in his present life, he is an associate professor of neurology and pediatrics at Emory University. In his clinical practice, Dr. Nahab focuses on prevention, treatment, and the rehabilitation from stroke. And he has been named one of Atlanta's top doctors for consecutive years. Everyone, please welcome Dr. Fadi Nahab. Thank you.
Thank you so much for the kind introduction, and I appreciate the time to speak to you all about a very important topic. As you actually heard, this is something that is something I do day in and day out with the goal of trying to reduce people's risk of having stroke. And so the topic that I'm going to focus on is actually how people can optimize their brain health through stroke prevention. And one of the things that's important is a lot of people are not actually aware that stroke itself, while it's the fifth leading cause of death in the US, that people think about the big strokes, the person who can become paralyzed on one side of the body or who can stop speaking all of a sudden. But in reality, we know that small strokes matter. And a lot of people aren't aware that they have small strokes until they may get a brain image, for example, an MRI. This slide here shows an MRI that's done, and normally people do not have any of this white stuff that we see in the brain. But this white stuff represents scarring to the brain and happens as a result of small, tiny strokes that build up progressively over time. And based on some studies, these kinds of small strokes are more commonly the contributor to memory impairment than big strokes are. And so some people will say, well, how do small strokes and Alzheimer's disease, how are they related? Because all of us want to avoid dementia, which is basically having disability due to some cognitive problem. Well, in this study that used and studied Catholic nuns who basically were willing to donate their brains after they died, what was understood was that people and the Catholic nuns, 57% of them actually had the abnormal proteins associated with Alzheimer's disease. But when you looked at the Catholic nuns who actually had small strokes on imaging, which were about 40% of them, their cognitive function was actually lower, even though they have actually had less of the Alzheimer's disease proteins seen. And so what this study told us was that if you had small strokes, and even if you had less of the abnormal proteins in the brain that were associated with Alzheimer's, those small strokes put you at a higher risk of having and developing dementia. Now, other studies have been done that have shown that when you look at people who have dementia, most of the times what you see in their brain is that they have a combination of strokes and Alzheimer's disease abnormalities that contribute to their dementia. In a British study, the strokes were actually more commonly what were seen in people who had dementia than was Alzheimer's disease abnormalities that were seen. And in a US study, it was actually the combination of Alzheimer's disease and strokes, or what we call cerebrovascular disease, that was the most common finding in people who had dementia. So people used to think about, well, on the left column is the abnormal protein we call amyloid associated with dementia and Alzheimer's disease. And on the right, vascular, which we refer to as cerebrovascular disease or stroke, and needs to think about, oh, these are two separate, entities. Well, in reality, what we've come to learn is that they're not completely separate. You have people who may have abnormal buildup of the amyloid protein contributing to Alzheimer's disease, and you have those same people who may have buildup of these small strokes causing vascular abnormalities, or what we term ischemia. Ischemia refers to lack of blood flow to a portion of the brain that leads to stroke. And that ultimately it's the two together that can actually contribute to dementia. So how common are these small strokes that I'm talking about? Well, some studies have shown that about 5% of people in a population can have these small strokes, but other studies have shown up to 55% of people can actually have these silent strokes when you do that. Now, overall, the largest studies would show that in people over the age of 60 years, it's about 3 to 4% per year that people are having silent strokes. And that when you get into the 80 plus year old category, it's actually double that, about 6.5% per year. Now, some of you may be aware that, small strokes can actually be the cause or can occur from having surgeries. And so some cardiac surgeries have shown that if you do an MRI after having a certain kind of cardiac surgery, upwards of 90% of people will actually come out from the surgery with a small silent stroke. And so again, it becomes really important to recognize these silent strokes, because not only can they contribute to developing dementia, but they're also preventable. This was actually a study that was done actually in Europe, and they actually took 60 to 90-year-old participants who are randomly chosen. They did not have dementia at baseline. And what they did was they did an MRI for them in 1995 to 1996. And then they had the participants come back in for a second brain MRI done about 5 years later. And what they actually found was that silent strokes were actually 5 times more common than people with the strokes that cause major symptoms like paralysis or speech trouble or facial weakness. And what they did see was that women tended to have higher rates annually of these kinds of strokes than men. So if you were in the 60 to 70-year-old range, 10% of women and 5% of men had an annual increase in the number of silent strokes. And by 80 to 90, you can see that the annual buildup of these silent strokes was upward of 25% in women and about 20% in men. So the natural thing to say is what impacts developing these silent strokes? Well, as we get older, we're more risk for developing these silent strokes. In addition to that, we know that diabetes is a big player when it comes to this. So diabetes was associated with a 3-fold increased likelihood of developing these silent strokes. And then the third column, the third arrow here is pointing to something called intima media thickness. That's a fancy medical term that just means you're developing thickening of the wall of your arteries, typically caused by high blood pressure, high cholesterol, and also things like diabetes and tobacco use. So what we know from this study is that having these silent strokes doubles the risk of developing dementia. The presence of these silent strokes in the second bullet results in a steeper decline in a person's cognitive function. And if we can prevent additional silent strokes from developing, we can actually reduce the cognitive decline that occurs. There was this interesting study that was done, and many of you probably would not want to participate in this kind of a study, but what it did do is it took patients and it gave them an MRI every single week for 16 straight weeks. And you can see they were only able to recruit 5 patients into this study, but it was important because when these 5 patients had their MRIs done, I showed you earlier about the white stuff in the brain that's representative of silent strokes. Well, you can see in all of these 5 patients that participated in the study, at baseline, they already had quite a bit of these white stuff, which we consider these silent strokes. And so what they did was they followed them out for, again, 16 weekly MRIs, and they were age ranged from 55 to 79 years old. None of them actually reported having new symptoms. And again, these become more in the silent category. And what they found was just in those 16 weekly MRIs that 3 out of the 5 patients who were part of the study were actually detected to have additional silent strokes, and they didn't even know it. They had no symptoms associated with it. And so overall, there were 9 new strokes in these 3 patients. The strokes were small, and they were most commonly seen in people who had high blood pressure, high cholesterol, and one who was actively using tobacco. So the question becomes, are all of these strokes truly silent? Well, there was a study which we did and we were a part of where we said, let's ask patients, participants in this study, and ask them, how often did you have a silent, painless, one side of your body going weak? How often did you have sudden one side of your body going numb? How often did you suddenly lose vision in one eye or both? How often did you lose one side of vision, say to the right side of the vision in both eyes? Or suddenly having inability to understand speech or to speak at all? And what was found in this study is these are all representative of stroke symptoms, yet 1 in 5 people who were asked actually said yes to a stroke symptom, though they were reporting that they never had had a stroke or a mini stroke before. The people who are more likely to report not having a stroke yet saying yes to stroke symptoms were more likely to be African American ethnicity, lower income, lower educational levels, and people who had fair to poor perceived health status. And we saw that with another study that was actually done in New York, where people were very, very frequently reporting that they had one side of their body weakness, what we call hemiparesis, very frequently having speech difficulty. And yet all of these people said no to having a history of a stroke. And we know that stroke has dropped to the 5th leading cause of death in the US with a lot of improvements with stroke care. But annually in the US, we have about 795,000 strokes. Now, these 795,000 strokes are actually representative of strokes that people are aware of. If you were to add in the people who are having silent strokes, some estimates suggest it would be upward of 11 million strokes that occur annually in the US. So this is a big, big issue going on there. We know that there are a variety of factors that lead to these silent strokes. As we talked about, some of them are related to age, sex, race, one's weight, cigarette use. We know risk factors like high blood pressure, high cholesterol, diabetes. Of course, genetics plays a role in this as well. We touched on the fact that some heart procedures can contribute to an increased risk of these silent strokes. And we know that blood tests can actually help to predict who are the people who are more likely to have these kinds of silent strokes. So what we care about most, what can we do to avoid these silent strokes and as well these symptomatic strokes as well? So the American Heart Association, American Stroke Association has put together something we call Life's Essential 8. And these 8 markers I'm going to go for are predictors and things you can do to help reduce your risk of having symptomatic strokes and silent strokes as well. They include 5 health behaviors, which include physical activity, like was mentioned earlier in the presentation, healthy diet, ideal weight, stopping tobacco use, getting good sleep, and then including 3 health factors: blood pressure control, cholesterol control, and blood sugar or glucose control. So number 1, we want physical activity to be at least 150 minutes per week. I tell my patients at least 30 minutes a day you should set aside in your calendar or in your day to basically go out and do a brisk walk. It doesn't need intense exercise. It needs at least a 30-minute brisk walk where you're breathing a little heavier. Number 2 is a healthy diet. So importance of a healthy diet comes from eating 4.5 cups per day of fruits and veggies, trying to minimize red meats and going more toward things like fish. Having fish 2 servings per week would be great. High fiber. Beans, nuts, fruits go a long way in helping that fiber-rich diet. Limiting sodium or salt in your diet. So we know that we want people to be less than 1,500 milligrams per day, but the average American has over 3,000 milligrams per day of salt in their diet. And then minimizing sugar-sweetened beverages. So the sweet tea, the sodas are all things we want to minimize with that. In addition, we know a healthy diet includes a Mediterranean type of diet that highlights the things that we've talked about. And we know in addition to the high consumption of the veggies and fruits, legumes, cereals, and fish, limiting saturated fats like butters and margarines, and also limiting, again, the red meats and going to low-fat dairy options if you're going to do that. Lastly, limiting alcohol use. In truth, 0 is best when it comes to your overall brain health. We also know that the more of a Mediterranean diet you have, the reduction in developing cognitive impairment and dementia that occurs. So having that kind of a healthy Mediterranean diet helps to reduce your likelihood of cognitive impairment. Number 3 is maintaining healthy weight. So it's important to work on losing weight, and losing weight, even 1 pound a week, is where you want to be, and it helps to reduce your likelihood of developing diabetes, high blood pressure, high cholesterol, and even sleep apnea, which is a drop in your oxygen levels when you sleep. All of these risk factors can increase cognitive impairment. Number 4, we touched on, is smoking and tobacco cessation. So it's not just smoking tobacco, but chewing tobacco, getting exposed to secondhand tobacco use. All of that increases the risk of Alzheimer's disease compared to non-smokers. So really important to try to actively avoid tobacco exposure. Number 5 is get healthy sleep. We want people to have at least 7 hours to 9 hours per night on average. Again, sleep affects your blood pressure, it affects inflammation in your body, it affects your blood sugar in your bloodstream, and it increases cardiovascular risk, including heart attack and stroke. So good sleep is critical to good brain function. Number 6 is blood pressure. An ideal blood pressure is a blood pressure less than 120/80. That doesn't require medicines. We know that blood pressure that's above 160 doubles your risk of developing Alzheimer's disease. And high blood pressure is called the silent killer because by the time that it's causing symptoms, it's already done so much damage, like those silent strokes I showed you on the images of the MRI. Number 7 is the total cholesterol, again, being at an ideal goal, which is a total cholesterol less than 200. Now, a total cholesterol greater than 250 actually doubles your risk of developing Alzheimer's. And again, with diet and healthy lifestyle in combination with genetics, we know plays a factor in cholesterol. But working on a healthy diet can help lower your cholesterol in addition to medications when needed for people who are having genetic causes of cholesterol, as well as a dietary cause of cholesterol that's high. And then lastly is a blood sugar level that's ideally less than 100 in the blood. We know from studies that if you have high blood sugars that lead you to have diabetes, diabetes can increase your risk of having Alzheimer's disease anywhere to 2 to 5 times higher risk in diabetics versus non-diabetics. So step 1, diabetes is very genetic. So if you have a family history of diabetes, making sure that you are getting that blood sugar checked out with your doctor at least once a year is really important, and making sure that you're getting that blood sugar well checked. This all together, those 8 markers I talked about for you, are able to kind of give you a sense as to how you're doing in terms of your health behaviors and also your health factors. And so looking at this can actually help to give you a picture of how you're doing, whether you're in the green or whether you're in the red. And so my final slide here is just to highlight the most frequent abnormalities we see in patients who have dementia is a combination of strokes and Alzheimer's disease abnormal proteins. Number 2, silent strokes are common. So even if you haven't had symptoms of stroke, they can cause cognitive impairment. And so it's really important to work with Life's Essential 8, these 8 factors I shared with you about, because they can help prevent cognitive impairment. They can reduce your risk of developing dementia. It can reduce your risk of heart attack.
Thank you, Dr. Now. This is Dr. Parker. So you've been telling everybody what they need to do to keep from having strokes. And this is probably one of the things that has been most important to, I think, our audience to basically understand the connection between brain dysfunction and strokes and how they contribute. So thank you for making all of those points for us and making them very well for us. For the people who haven't been diagnosed with a stroke but may have high blood pressure or high cholesterol, is there something that they can do or should do to be checked before they actually have a stroke?
So that's a great question, Dr. Parker. And because the number 1 risk factor associated with stroke is high blood pressure, and because it's considered the silent killer where it may not cause symptoms, I tell everybody to invest in a good blood pressure machine. If you don't have a blood pressure machine that includes a cuff that measures above the elbow, it is really critical to get yourself a blood pressure machine. And depending on your insurance, some insurances will actually cover your cost of getting a blood pressure machine. That blood pressure machine and learning how to check your blood pressure and making sure that if your blood pressure is less than 130/80, you're doing the right stuff. If it's above 130/80, that's where you need to report that to your doctor and check it out with your doctor and talk to your doctor about the things you can do to lower that blood pressure. It's going to be a combination of diet that includes low salt in your diet. It's also going to be a combination for people who need medications to actually take medications to help reduce their blood pressure. It's a very common thing that people tell me, well, doc, I really don't want to take a lot of medicines. And I tell them, I'm with you on the same page. We want you to take as few medicines as possible. But at the same time, there is nothing more detrimental than keeping your blood pressure high while you're taking limited medications. If your blood pressure is high, we got to get that blood pressure to the goal. And for some people, it's one medicine. For some people, it's two medicines. For some people, it's three medicines. Bottom line is we need that blood pressure well controlled.
There is a question in the chat about a silent stroke. Can you define that a little bit better for people? What does that mean?
Yeah, so it's a great question. So a silent stroke is a stroke that is apparent on brain imaging that can be done with a CT or CAT scan or an MRI of the brain that did not manifest with symptoms that the person was actually aware of. And so sometimes, most commonly, I will tell you that people may have a brain image where they have a CT scan or an MRI of the brain, and they have it ordered for some other reason. Let's just say somebody has a headache, and their doctor orders an MRI scan, and the MRI scan comes back with, you have had prior strokes. And the person may say, well, I didn't know I had a stroke. I never had paralysis. I never had vision loss. I never had face drooping. So where did this come from? That itself is basically representative of a silent stroke. Is you see the damage on the brain imaging, but you were never aware of any symptoms suggestive of it. I do see some questions in the chat that I can speak to as well if we have time for another question or two. One of them was actually centered around somebody mentioning about having had a TIA. And people may ask actually about TIAs. And I'll just share with you all that
Can you hear me?
TIA is basically a warning sign of a stroke, just like chest pain is to a heart attack. And so a TIA itself basically is a brief stroke symptom that comes and goes on its own. And when it goes on its own, you shouldn't think that, oh, I'm out of the woods. If you're having brief episodes of one side of your body going weak or slurring of your speech, that's a sign that something's not going right in your brain, and it becomes really important to get that checked out, and even calling 911 is appropriate.
Hi, Dr. Nahab. There's a very good question in the chat about the difference between vascular dementia and vascular Parkinsonism. Can you cover that? That's a very good question. I think that a lot of people will find information about them more helpful because they do look a lot alike.
So that's a great question. So the silent strokes that I've mentioned can occur in different parts of the brain. When they occur in certain parts of the brain that are controlling our movement of our body, whether that's our arms, our legs, even our ability to walk, those areas, when they're damaged, they can actually lead to people looking like they have Parkinson's disease. But the classic Parkinson's disease is not due to strokes. It's due to other abnormal proteins that build up in the brain tissue. So it's very difficult to basically tease apart when somebody has Parkinson's disease due to strokes, what we term vascular Parkinsonism, from Parkinson's disease due to non-stroke causes. And typically getting a brain MRI or a CT scan can help to tease those apart. Now, if people have silent strokes, in a different area of the brain than the movement centers of the brain, but rather in the memory centers of the brain, then that can lead to vascular dementia. And we term dementia for people who have such impacted cognitive function that they can't do their day-to-day life activities independently, and they need assistance with that. And again, some people will actually have family members who have trouble with memory and forgetfulness. And sometimes people will say, well, my loved one has dementia and it's Alzheimer's. But if you haven't actually had any brain imaging, you may actually miss that your loved one may actually have vascular dementia, which are strokes causing that dementia. And as I've shared with you all, vascular dementia comes from strokes, and we have such effective ways to prevent strokes. We don't want to wait until somebody has vascular dementia to say, okay, how can we prevent this from getting worse? We want to reduce the vascular insults, the vascular strokes from happening early enough so that you don't have memory impairment and that you're not reaching the point of dementia.
Right. So one thing, Dr. Nahab, is you mentioned the term Parkinsonism and Parkinson's disease, right? I don't expect the lay public to really know the difference between the two. Now, as physicians, we do know that difference. And I think this may be a very good opportunity to give our audience some insights about that difference, because it can be critical.
So one easy way I like people to think about whether it is Parkinson's disease or Parkinsonism is we have an acronym called TRAP. T stands for tremor. So many people who have Parkinson's disease can have this resting tremor. And we actually refer to it's almost like a pill rolling tremor. So you can see it's almost like if you had a pill in your hand and you were actually rolling it, you'd see this kind of a pill rolling tremor. R in TRAP represents rigidity. So that's basically these people who are very rigid in terms of their movements. A refers to akinesia, which is just a fancy medical term that actually means that when you look at these people who have Parkinson's disease, they actually have a very flat face. They may not be blinking very much. Their face is almost just kind of like looking at you in a fixed gesture. And then P represents the posture. And so the posture and the balance is off. So when you have that, any of those symptoms of TRAP, tremor, rigidity, this, what we term akinesia, and postural balance trouble, that can be consistent with Parkinson's disease. Some people who don't have the classic Parkinsonism, the classic Parkinson's disease, can get worse and worse. And if they get worse and worse in their symptoms, that can cause Parkinsonism, which looks like Parkinson's disease, but instead is due to small strokes that are building up over time.
Got it. Thank you for that explanation. Someone posted a question about headaches in a parent who is taking multiple blood pressure medications. They would like some guidance. Is there anything that they can do? As a neurologist, what additional steps would you recommend? Because clearly the goal is to prevent strokes or TIAs.
That's a great question. So we know that for some people, headaches can be a manifestation of having very high blood pressure. Sometimes headaches come and they're unrelated to blood pressure. I do think when you're having a headache, I do think it's a good idea if you have that trusty blood pressure machine to check your blood pressure to see if your blood pressure is high. Because if it is high, we know that getting better control of that blood pressure can also help to reduce the headache intensity with that. If you find that your blood pressure is normal, but you're having a headache, that's a sign that there may be a headache going on that's causing that's being caused by things other than high blood pressure. Bottom line is if your blood pressure is regularly above 130 for the top number or 80 for the bottom number, that's something you need to do something about. Don't just say, oh, I have high blood pressure and my loved one, my parents had it, my brothers or sisters have it, and that's just what I have to live with. That's something you have to take initiative on and make sure to lower the salt in your diet and then see your doctor to discuss treatment options.
Right. So speaking of blood pressure, can you elaborate on the bottom number? And I guess for good measure, the top number as well.
Sure. So what we know when we're checking the blood pressure is when your heart pumps, with each pump, that initial strong pump itself causes the blood flow to have sort of a peak or a high point of the blood pressure that we call the systolic blood pressure. That represents the top number. And that's the top number that we want to be less than 130. Okay? The lower number, which you'll hear called the diastolic function, is actually what your blood pressure is when your heart actually stops that pump and where the blood flow continues to maintain blood flow to the rest of your body. So that number is we target less than 80. And we refer to diastolic because diastolic blood pressures that are above 80 can also cause problems, just like the top number above 130 can cause problems. Now, the reality is as we all get older, our arteries stiffen up. And a stiff artery or a stiff pipe causes the top number to get higher and the bottom number to get lower. It's really important to be aware that as we get older, all of us are more and more likely to get that top number going higher and higher. And some studies suggest that 80% of Americans in their lifetime will have high blood pressure. So you may not have high blood pressure when you're 40, 50, or 60, but by 65, you may start having high blood pressure. By 70, 75. And many of us know we have people who have high blood pressure who are in their teens or 20s or 30s. So it's really important not to take for granted that, oh, I'm 40. I don't need to check my blood pressure. No, you need to be checking it on a regular basis and being aware of where your blood pressure sits.
Okay. Now, there was a very interesting question in the chat. It's a multi-part question. So if someone has, or if they experience joint pain, I guess thigh pain from taking a cholesterol medication, can high cholesterol be addressed by red rice yeast with coenzyme Q10? And the second part of that question, I think it really points towards more of a precision medicine consideration. Do people who have less melanin tend to have higher cholesterol? So, part one, can red rice yeast with coenzyme Q10 be used to control cholesterol? And part two, individuals with higher melanin expression tend to have higher cholesterol. Less melanin expression.
So let's talk about that because that highlights the importance of the cholesterol control. And so cholesterol control, we know that yes, diet plays an important role, which is and you can reduce your cholesterol levels by reducing saturated fats. The butters, the margarines, the red meats, that's important. But we also know that high cholesterol is very genetic. And in people who have genetic causes of high cholesterol, you can do all the best things in the world to get your diet well controlled and your cholesterol still remains high, especially that LDL or bad cholesterol that we do. So as mentioned in the question, we know that statin medicines can lower that LDL effectively. but people can sometimes have side effects from statins that can include joint pain or muscle pains. And for some people, it's so severe that they can't take the statin at all. It's important to realize that we don't have only statins as an option for lowering cholesterol. So one of those that was mentioned was, it's actually called red yeast rice, abbreviated RYR. And red yeast rice has a naturally occurring statin in it called lovastatin. Red yeast rice, I do sometimes prescribe to patients to help lower cholesterol. There is one downside to red yeast rice, is because it's not as potent, you have to take more capsules. And so for people, typically, you have to take like 3 capsules in the morning and 3 capsules in the evening to actually get the benefits of it. Now, some people love taking capsules. And if you do, well, red yeast rice may be an option for you. But if you don't, that's where other options are there. You also mentioned in the question about coenzyme Q10. Studies show that if you take a statin and that you have muscle cramping or joint pain, that can be related to a low coenzyme Q10 level. And so taking coenzyme Q10 supplements of 200 milligrams daily, which you can get over the counter, can actually help to reduce the side effects from taking a statin. And so I do recommend that, especially in people who have side effects from the statins. Lastly, you asked about less melanin tending to have higher cholesterol levels. I will tell you that it's not so much related to the melanin per se, but we are doing studies here at Emory on something called lipoprotein A. Lipoprotein A, we have seen, is a genetic marker associated with higher cholesterol. And actually, African Americans tend to have higher levels of lipoprotein A. And so it does appear to be the case that different ethnic groups have different frequencies of lipoprotein A. And we are sharing more and more and more with not only patients, but with the community to talk about lipoprotein A, because we are testing out new treatments separate from statins that may actually help to reduce this elevation in lipoprotein A and may help to reduce heart attack and stroke risk. So stay tuned.
All right. Fascinating. So do you have any patients on the red yeast rice?
I do. And so I usually have that conversation with patients to say, your LDL or bad cholesterol is high. And if your LDL or bad cholesterol is high, we have different options. Step 1, we always want to work on the diet. So making sure that they're doing all they can from a dietary standpoint. Step 2 is saying, in addition to diet, we have these statins. And sometimes I have patients who say, you know what? My loved one took a statin, or I've heard bad things about statins. What do you think? I'll talk to them about the statins, and I'll tell them that for a lot of people, statins are great, great medicines. But if they are reluctant to take a statin, I will put that patient on red yeast rice and offer that as an option. We also have other options that are prescription options that are not statins that can actually help to lower cholesterol levels. Those may be medicines that you all may have heard of called Zetia or Nexletol that are not statins, but that can lower it. But yes, I do have patients on red yeast rice, and they do tend to be patients who do like to take supplements. And if they do like to take supplements, I will encourage them to take a certain type of red yeast rice to help lower their cholesterol down. And then we will always follow up with repeat cholesterol level checks to make sure that the red yeast rice is lowering their cholesterol.
Okay. Yeah, that's all I was asking. I was curious to know how it's working, say, if you were to compare it head on to people who may be on a traditional statin or, a statin alternative that's prescription only.
So there was actually a study that did just as you're mentioning, where it compared people who were taking high dose red yeast rice, and they were comparing it to people who were taking a moderate dose statin. And they actually showed that the LDL numbers, the bad cholesterol numbers, actually were reduced similarly. Now, some people need to be on a high potency statin because their cholesterol level is just so high. If they're in that category, red yeast rice by itself is not enough. But in people who have a mild or moderately elevated level of their LDL cholesterol and who don't want to be on a statin, I do think red yeast rice is a reasonable option.
All right. Okay. So it doesn't necessarily mean that everyone on the call should run out and start taking red yeast rice today, though. So there are some interesting questions, and if we can just close out with these last two. So one, an individual says that their mother, they had a TIA about 15 years ago, and afterwards they had a pacemaker / defibrillator placed. They want to know how they can analyze if they've had more TIA events. The second question is related to statins again. As you know, there is some literature rather saying that some statins can have adverse effects on cognition, memory, and thinking. Then there's also the school of thought that it's better to treat the risk, especially when it comes from vascular dementia. So what are your thoughts? One, how can you analyze for more TIAs? And two, can you comment on whether it's better to take a statin to reduce risk of vascular brain insults or avoid them because of their cognitive effects?
So both great questions. I know for the sake of time, we don't have a lot of time, but I am going to share opinions about both questions about it. Number one, by definition, a TIA is so brief of a stroke symptom that it doesn't cause any permanent injury in the brain. However, people who have TIA symptoms are more likely to have had prior strokes on their MRI if one was to do an MRI. And so, step one, if you are concerned that you have had a TIA in the past or recently, that needs to be discussed with your primary care doctor to discuss with them about that TIA. They will likely order an image of your brain with, for example, an MRI or a CT scan, and they may refer you to a neurologist. Based on that evaluation, you will be able to know, have you had prior silent strokes? What was the cause of those silent strokes? And how can you prevent not only future silent strokes, but also prevent TIA going forward? With regards to the question about statins and cognition, it's a great question. I will tell you, I keep a very close eye on the literature because the last thing I want to do is hurt anybody with any of the treatments we have.
Right.
What we know from that literature, from that research, is that people have such high rates of silent strokes when they come in with cognitive impairment and dementia. And so the challenge becomes, well, a person who has all the silent strokes that I'm showing you on their MRI, but they didn't get an MRI yet. So many of those people come in with cognitive impairment or dementia, and maybe they've had some heart problems and their doctor put them on a statin because of their heart problems. Well, if they never got evaluated with a brain image and they have dementia, they could falsely start to think that it's the statin that was causing the dementia. And not until you've had a brain image to look and see, hey, have I had silent strokes? Have I had big strokes? It's not going to be apparent until you've had the brain imaging. Once you've had the brain imaging, then you can have a better sense of, hey, are statins a good idea? If there are a lot of silent strokes, I'll tell you statins are an absolute good idea. If you haven't had silent strokes on the MRI of the brain, then the answer may be, you know what? Statins may not be necessary for you. Bottom line is you need to talk with your doctor about it. You need to, if appropriate, have that doctor consider brain imaging. And then based on that evaluation, as neurologists, as primary care doctors, we can work to help optimize your life's essential 8 to minimize your risk of silent strokes as a whole, and dementia together.
Wonderful. Thank you, Dr. Now. Emily, do you think we can download the chat? Because I know there were some additional questions that we didn't quite get to, and they're very good questions.
Lots of great questions in the chat, and we'll try and get back to you all and take that survey that we have for you, because we can get more questions that you ask there, and we'll try and get all the responses that you need. Dr. Nahab, thank you so much for coming on the program today. I'm sure we're going to forward a few questions to you, because I think there's 206,000 in the chat right now. So a vastly huge number. But thank you so much for joining us today.